Welcome again. This is Yasser Wasifi from Learn Dental Series. It's a great pleasure to me to meet you again at this episode where we will continue our discussion about diagnosis and treatment planning in operative dentistry. I would like firstly to declare that I don't receive fees, compensation, or royalties from the sales of any of the products shown or discussed. Also, this presentation has not been sponsored by any company, agency, or organization and only prepared for educational purposes. This presentation is copyright protected and could not be transmitted by any means unless you have a prior permission from the author. In this episode, we will continue our purpose to design the roadmap for proper treatment planning by properly diagnosing the non-carious tooth defects or other developmental tooth defects. In the first part, we already discussed patient assessment and information gathering. Then we come forward for clinical examination and diagnosis. We already finished in 3 episodes the diagnosis of dental caries, including traditional techniques and advanced caries detection aids. Also, we discussed different techniques for caries risk assessment. Then we discussed examination of existing restorations, including amalgam, composite resin restoration, and indirect restoration. Today, in this episode, we will discuss how to examine other tooth defects, including developmental defects, chemical erosion, abfraction, abrasion, attrition, and fracture line. Let us go on, okay, and we will start with developmental defects. What are developmental defects? As the tooth develop and form, they are at risk of developmental defects that manifest clinically after tooth eruption. We couldn't discover it while still the tooth is unerupted. Okay, it is not like pregnancy that gynecologists could discover any developmental defects while ultrasonographic the fetus. Here we couldn't discover it until it is erupted because we don't like to expose our young born or newly born children, okay, to radiograph because this is the only way to discover the condition of the tooth development. And also, even if we have a radiograph for a newly born child, we couldn't discover it accurately. Okay, these defects may be in the quality and the quantity of mineralized tissue, may be affect the size, shape, or number of teeth itself. Most probably, these defects manifested as aesthetic defects. The problem is in that most of the tooth germs, okay, of permanent teeth are not presented at birth, okay, and that's why we couldn't discover it unless it is erupted, okay. For proper diagnosis of these defects, we should clinically examine it perfectly, but this is not the only successful way of diagnosis. We should have a careful history taking, okay, especially of childhood or maternal illness or trauma of the deciduous dentition. These defects could be manifested either as acquired defects or hereditary defects which has a familial history or genetic pattern. Acquired defects may be in a form of enamel hypoplasia, molar incisor hypomineralization, intrinsic dental fluorosis, and intrinsic tetracycline stain. Okay, hereditary may be in a form of congenital malformations or genetic patterns with familial history manifested as hypodontia or oligodontia, amelogenesis imperfecta, and dentinogenesis imperfecta. Most of these cases, except fluorosis, are nowadays extremely rare. Even fluorosis is now decreasing or declining, okay, because all of us are using now tap water, not urban areas, okay, using wheel waters and water sources like that. Also, controlled fluoride intake, okay, takes place through governmental health organizations that controls the amount of fluoride in our water. Okay, let us start with the acquired ones and start with enamel hypoplasia. Enamel hypoplasia means that there is a damage, okay, in ameloblast, okay, either due to systemic childhood infectious diseases, trauma, or infection to deciduous predecessor, okay, that leads to defects or damage of the ameloblast of the permanent coming teeth, okay. It is either in a form of hypoplastic enamel, that means that there is a deficiency in enamel matrix but normal maturation and normal mineralization, or maybe in a form of hypomineralization. It is the controversy of hypoplastic teeth. It is a normal matrix but with decreased mineralization. In case of it is hypoplastic, okay, due to decrease in matrix of enamel, okay, but with normal maturation, then it appears as pitted thin enamel or normal of normal hardness. The difference will be in the hardness because mineralization, okay, this is the main item or the main factor that affects the hardness of enamel. As long as the enamel is well mineralized, okay, it will get harder and harder, okay. Then hypomineralized, it appears opaque, chalky white, like that of acid etching, okay, and softened enamel because the amount of mineral content is decreased and the hardness is also decreased, okay, maybe due to systemic causes, okay, and at this time it will be defined areas, okay, of bands on all teeth depending on the time of illness, okay. If the patient getting rise in body temperature, okay, of your case getting rise in body temperature due to fever during the childhood, okay, may affect the quality of your ameloblast and its function, and resulting in bands of defective enamel, and the width of this band is related to the time of illness or the time of fever. Those photographs showing different grades and shapes of enamel hypoplasia, okay. Then, as you could notice, most probably the patient is coming complaining from aesthetic problem. He is not in satisfaction with his smile, okay, is not satisfied by his shape and form of his teeth. That's why the main problem or the main patient complaint will be aesthetic. Let us continue also to another case of acquired defects like molar incisor hypomineralization. It is similar to that of hypoplasia, okay. It is due to systemic illness like high fever or respiratory illness from 0 to 2 years affecting occlusal surfaces, okay, on the first molars and possibly maxillary incisors, which are their germs are present inside the jaw at this time, okay, from day 1 of birth up to maximum 2 years. It appears as hypomineralized area, okay, and also this hypomineralization may follow orthodontic treatment as well, okay. That's why it is acquired either from birth or the patient may have a history of orthodontic treatment, okay. It appears as white yellow or yellowish brown opacities, easily chipped, okay, due to hypomineralization, increased sensitivity because of exposed dentine. Maybe there is a black stagnation to the area due to microporosity of enamel, okay. Those are many examples of this, okay. Photograph A showing molar hypomineralization at ridges and cusp tips, okay, while B incisor hypomineralization, and C hypomineralization following orthodontic treatment, especially if your patient is consuming acidic beverages or carbonated beverages too much at this time, okay. And at photograph C, you could notice the place where the braces were bonded to the tooth structure and hypomineralization appears all around it due to improper maintenance of oral hygiene during orthodontic treatment. This is a case of one of my students, Abdullah Walid Al-Jayar from Taiba University, showing a hypomineralization following orthodontic treatment. In such a case, you should have an exact history of the case, okay, and exact record of the patient history. If he is subjected to fever or illness at the early childhood, okay, or he is receiving orthodontic treatment. In the case of receiving orthodontic treatment, you could note that it is affecting a segment of the tooth, not a tooth itself. Okay, if you find these hypermineralization or white spot lesions, okay, only in the two centrals and on the first molar, then it is related to early childhood fever. Okay, because as we mentioned before, those are the tooth germs present or found on the jaw at this time or at this age. But as you note in case C, and in the coming or in the case we discussed, okay, in case of it is related to orthodontic treatment, okay, you could find these hypomineralized enamel and these white spot lesions or white lesions affecting at least the anterior segment as this case and as this case. Okay, then coming, okay, the acquired dental fluorosis, intrinsic dental fluorosis. Okay, dental fluorosis is due to excessive fluoride ion intake, okay, either from water, toothpaste, tablets containing fluoride, that poisoning the ameloblast, affecting its function during enamel formation and maturation. Okay, then it is a state of poisoning of ameloblast due to fluoride. Okay, and at the same time, fluoride is a competitive inhibitor of calcium, okay, deposition, and it takes place instead of calcium. Okay, it's the same as the intrinsic tetracycline stains. At this time, enamel appears chalky white, okay, flecks, okay, confluent blotches, brown discoloration, pitted enamel surface. All of these are related to extremely high hardness enamel. Okay, and this high hardness enamel, okay, is porous and full of cracks and porosities due to its increased hardness. Okay, and that's why there will be a different degrees of discoloration according to how much your porosities are filled with extrinsic stains. It is intrinsic dental fluoride, but at the same time it gives a chance through its porosities to be occupied by different stains. Okay, at the same time we have another competitive with the calcium deposition, which is intrinsic tetracycline stain. Okay, it's a broad spectrum antibiotic with great affinity for mineralized tissues. If taken by mother during pregnancy, okay, deciduous teeth are affected. If it is taken at age less than 12 years and for a long time, then permanent teeth are affected, okay, according to which teeth are present at this time, but most probably it affects the whole permanent set of teeth. Nowadays it is very rare because already use of tetracycline now is very used. It appears as dark gray horizontal bands affecting all teeth. The degree of darkness is and the width of your bands is affected by the time and the dosage of your tetracycline intake for this case. This is the Dean's fluorosis index, okay, starting from normal 0 up to severe coded 3 or scored as 3. 0, it's a normal enamel surface, smooth, glossy, okay, without any discoloration. It appears creamy white and translucent. Okay, mild, scoring 1, okay, for Dean's fluorosis index, and it's a very important topic, and it will be discussed in separate episode, okay, in full details. Okay, we will discuss dental fluorosis and how to manage it. Okay, score 1, which is mild, started to appear opaque white areas. Okay, it seems to cover, or he scored it as covering less than 50% of tooth surface. Then if it comes more to cover more percent of tooth surface, then it is upgraded to be moderate, okay, scoring 2. All tooth surfaces are affected, marked wear on biting surfaces because of increased hardness of enamel that let it chipped easily, okay, and starting to have brown stains that may be inspected or could be discovered. Okay, then severe, where all teeth are affected with discrete or confluent pitting and brown stains are present. The coming photographs is much more descriptive than that of Dean's classification. Also, it is based on Dean's classification. Photograph A is a very mild bands, as you could see, okay, appears at the centrals, okay. Then it starts to be much more aggressive in photograph B. Then in photograph C, it's a moderate one, while D and E is described as mottled enamel, because of it is a severe case with much more porosities that are already saturated by extrinsic stains. The major differential factor in such a case, you may be in confusion or misdiagnosis between hypomineralization and fluorosis, especially in very mild and mild cases, okay, is the history of the patient. That's why it is important in your demographic data, okay, as we started for patient assessment, to get his address, to get where he lives, where he the birthplace, okay, and get history about all of these and what are the lifestyle at these areas, okay. This history is beneficial when you are differentiating between hypomineralization, white patches, and the early and very mild cases of dental fluorosis. Both of them appears as white spot lesion, but how could you differentiate? Okay, it's based on the medical history of the patient, okay, starting from the childhood. Did he subjected to a systemic disease, a systemic fever? Okay, does he has a previous orthodontic treatment, or he is living in an urban area with well water, okay, full of minerals, or he received the fluoride therapy in a high doses, okay. All of these with the clinical picture, with the proper clinical examination, can differentiate between all of these white spot lesions, okay. What is the importance of differentiation? Because the treatment mostly is the same. The treatment is aesthetic treatment, including correction of tooth form, correction of tooth color and shade, and finally it will be veneers, okay, direct or indirect, some sort like that, okay. And the fate of your treatment is the same. No, actually this is not true. This will affect the bonding technique you will use. This will affect the instructions you will give to your patient, okay. This will affect the fate and the prognosis of your case, okay. That's why you should decide, okay, accurately what are the etiological factors or what are the causes of your condition, okay. For tetracycline staining, okay, it's obvious. You couldn't miss it or misdiagnose it. It's a grayish brown bands, okay. Either it is mild, giving you a little bit shadow like the photograph to the left, or much more aggressive like that in the middle, or highly aggressive extensive case like that to the right side, okay. All of these cases are tetracycline staining, okay. You could diagnose it by color, it's obvious, okay, and you couldn't miss it. And as you see, the band and the degree of discoloration, the width of your discolored band in the teeth, okay, and the degree of discoloration is affected by the time of treatment, of receiving treatment with tetracycline, and the dose of tetracycline, okay. Then comes the hereditary lesions or developmental defects, including hypodontia. Hypodontia means that some teeth do not develop or associated with microdontia, like third molar, second premolar, and most commonly are the upper lateral incisors, okay, is the most commonly affected and appears as a big-shaped lateral. It is the most common one, okay, with abnormal crown shape and size. Then comes also amelogenesis imperfecta. Amelogenesis imperfecta, from its name, it's an abnormality in enamel formation, okay. and it has a complex classification. It is either appears as hypoplastic defect of the matrix formation or hypomineralization. It's a defect in maturity due to defect in matrix mineralization and maturation. Okay, for the case to be hypoplastic related to amelogenesis imperfecta, okay, it is appears as very thin enamel, yellowish teeth due to dentine showing through. This is the difference between it and the enamel hypoplasia. Enamel hypoplasia, okay, which is acquired one, is either a defect in mineralization or a defect in maturation also, but the difference here is the enamel is thin. It doesn't appear pitted, okay. It is mostly thin with yellowish discoloration due to dentine showing through. It appears mostly granular. Okay, sometimes it appears pitted, but it is a stained thin enamel. Okay, it's easily to be stained because it could receive stains from outside. At the same time, it shows the underlying dentine. Hypomineralized and the hypomaturation, defective matrix mineralization and maturation, the enamel appears very soft and friable. Okay, stained, sometimes it is chalky white enamel, okay, and frequently lost due to weakness at the dentine enamel junction. Okay, that's why sometimes dentine appears, okay, frankly by eye, naked eye. This is different photos of microdontia, okay, as a developmental defect for tooth form and size. Okay, most commonly, as we discussed before, is the upper laterals. Okay, appears as big shaped lateral, as you could see different photographs. This one is amelogenesis imperfecta. The first one is mild and the second one is severe one. Okay, where you could note that your enamel is pitted. It seems to be covered by black. Actually, it is covered by dental black and attracting black accumulation because of its pitting. Okay, but you could now note how thin is your enamel. Okay, then comes dentinogenesis imperfecta. Dentinogenesis imperfecta is a odontoblast defect affecting dentine matrix formation and mineralization. It's a very, very, very rare condition, but it is characterized by enamel loss. Why enamel is lost? Because enamel is a very hard and it is laid on, okay, a very soft dentine. That's why it is peeled off. Your enamel is chipped, okay, and the tooth appears brown, okay, with opalescent dentine color, okay, easily to be fractured. The teeth, if it is examined by radiograph, you could note that short roots, bulbous crown, pulp are obliterated also. But you could note from this photograph how aggressive is dentinogenesis imperfecta, and thanks God it is extremely rare one. Then please take this note. For these developmental defects, okay, proper diagnosis and treatment planning for developmental tooth defects are not only a matter of clinical appearance of the defect itself, but as we discussed, you should get a perfect patient and family history and search for other associated localized oral and generalized systemic abnormalities. Let's go forward for chemical erosion. Chemical erosion is defined as the loss of tooth structure, hard tooth structure, by chemical action in the continued presence of demineralized agent with low pH, like that of tooth brushing may be a contributing factor, okay, and may add much more frictional action for this low pH substance, okay, and it results in defective surface loss, okay, which is usually smooth, okay. The areas of these affected can be important in helping the clinician determine the possible source of the chemical action contributing to erosive process, okay, as if it is to the outer surface. This means that the source is exogenous and many agents are considered as exogenous low pH acidic media, just like simply as lemon juice, okay, and especially in those who are habitually lemon suckers, okay, may cause crescent-shaped or dish-shaped defect on the cervical area of the labial surfaces of anterior teeth or the exposed teeth. And if you find the loss of tooth structure in a palatal area, then the contributing factor will be endogenous acidic agent, which comes from the stomach due to gastric fluid caused dissolution or erosion in lingual, incisor, and occlusal surface. This is common in patients with bulimia nervosa, patients with gastric disorders, and in case of pregnancy. It's a common defect in women with frequent pregnancy. Okay, those are chemical erosion, okay, with different shapes, as you could notice in figure A, crescent-shaped defects on enamel facial surface by exogenous demineralizing agent. Figure B, erosion caused by endogenous fluid from the stomach, okay, due to excessive gastric juice. And C is a mirrored clinical palatal view of anterior dentition with erosion caused by excessive consumption of dietary acids. And at the same time, it may be the figure, if it is a female, you may expect, okay, frequent pregnancy. Then comes a most common nowadays lesion, which is abfraction. Okay, abfraction is related mainly to stress due to abnormal eccentric occlusal habits like that of bruxism and the clenching. Okay, it results in flexion of the teeth and abfraction of the cervical enamel. That's why the lesion appears in a wedge-shaped lesion. Okay, mainly due to heavy forces, especially eccentric one. It is related to most commonly to stresses and appears as a wedge-shaped lesion due to microfracture of enamel. Also, it is called idiopathic erosion. Okay, this is the result, wedge-shaped cervical lesion. And in figure B, you could note even there is a wear at the incisal edges due to excessive eccentric occlusal forces. Then comes abrasion. Abrasion is abnormal loss of tooth structure resulting from direct friction forces between teeth and the external object or teeth and each other, okay, in presence of abrasive media. Such wear may be caused by improper tooth brushing, especially horizontal technique, may be at the incisal edge due to pipe stem, if the patient is recording as he is a pipe stem smoker, okay, holding the pipe stem between teeth, maybe tobacco chewing in certain cultures and in certain citizenships, okay, that use tobacco chewing, especially Africans and Yemenis. Okay, this tobacco chewing is chew itself is put inside the buccal vestibule, and he is trying to suck it, okay, inducing friction at the cervical area of molar, okay, or who are holding pens sometimes or pencils. Sometimes it is related to occupational hazards. That's why it is important to record the patient education, as we discussed in demographic data that may reveal some occupational tooth loss, okay. But the most commonly now is toothbrush abrasion, which seems to be a wedge-shaped lesion, okay. Sometimes it is not in need just for a restorative intervention, just to stop and to correct, stop the wrong toothbrushing technique and educate your patient how to use toothbrush, okay, changing the toothbrush itself, changing the dentifrice you use, okay, and stops all of these. And sometimes it may be very aggressive, okay, that needs restorative management, okay. What is the difference in management between wedge-shaped lesion for abfraction, okay, and wedge-shaped lesion for abrasion? the difference in selection of restorative material. Okay, both of them are need to be restored if it is very aggressive, if it affects the aesthetic of the patient. But the difference in selection of restorative material, in case you have a wedge-shaped cervical lesion due to tooth flexion, okay, which is idiopathic erosion, then you are in need for a material with low modulus of elasticity, okay, just in order to yield with this flexion until the patient is treated and stopped it, okay. But for cases of extensive wedge-shaped lesion, okay, due to abrasion, you should consider the wear resistance of your material much more than the elastic modulus. In general, for cervical lesion, we are in need for a lower modulus material than occlusal one, okay? But in such a cases due to abrasion, okay, you should determine the wear resistance of material and using a material with high wear resistance at this area, okay? This is another one while the patient is holding pipe stem, okay, and you could note the curvature of the pipe stem at this area, okay. In such a case, the patient should stop this habit, okay, should correct the occlusion, and according to the degree of damage, we could take the decision either for direct composite restoration or a veneer, indirect or direct, and what is the type of restorative material according to the condition of the occlusion at this time, okay. Then comes attrition. Attrition is considered as a mechanical wear due to function, okay. It's a functional loss of tooth structure, maybe was accelerated by some parafunctional habits, but it is mainly related to old ages rather than young ages, okay, because it is considered as a functional physiological one with a little bit parafunctional movement of the mandible, okay. Abnormal attrition is present in patients, okay, whose young adults, okay, according to this type of occlusion, if they have a parafunctional one, okay, but it is very rare. In old patients, enamel of the cusp tips and incisal edges are worn, resulting in a cup-shaped, okay, or a cupped-out areas, okay. Sometimes there is no actual treatment for this, okay, except if this cup-shaped lesions is annoying the patient because of injury of the tongue or soft tissue, okay, it may have a sharp margins, and sometimes it is attracts food for to be retention, okay. These sharp edges could bite on the tongue, okay, or could hurt the tongue. It needs just only smoothing in most of cases, but in certain cases you are in need to correct the vertical dimension, okay, because it affects the vertical dimension of the patient and resulting in angular cheilitis at the corners of the mouth related to the loss of vertical dimension, okay. And that's why sometimes the treatment is very simple, just as smoothing the rough margins of the cup-shaped lesion, and may be complicated due to you are in need for occlusal correction. Those are cases of generalized attrition, okay, related to parafunctional habits of the movement at early age, and the other one be showing the cup-shaped, okay, cupping lesions associated with attrition for old ages. This photograph is very interesting. It's showing a multiple lesions of the hard tooth structure rather than even caries. You could note that there is for lower right lateral there is a class 5 lesion, okay, restored with defective restoration, okay. You could note also a wedge-shaped lesion at the upper left area, okay. You could note also exogenous erosion due to exogenous to centrals due to using extrinsic source of acids, it having a multiple factorial or multifactorial etiology. Okay, you could note many types of tooth wear: attrition, erosion, cervical abrasion. Okay, and the patient is middle-aged. Okay, finally, fracture line or cusp. Fracture line, okay, and these are often visible, especially with advanced aging, okay, due to increased hardness of enamel. That's why you may note crazed lines in your enamel surface, okay. It's common due to this, okay. Sometimes it is noted and sometimes it is misdiagnosed, okay. But if you are using transillumination, you may discover it, okay, accidentally while you are diagnosing dental caries or any other defects, okay. Detection of fracture line can be done either by dye material or light reflection by dental mirror, okay, or by microscope, as we discussed before, okay. Any tooth that has an extensive restoration, especially if it is not a bonded restoration, is expected to have fracture lines and expected to have weakened cusp. Okay, that's why if your patient having an extensive amalgam restoration, then re-examine your weak cusps for the presence of fracture line. Okay, the most common fractured cusps are always the lingual cusps of mandibular molars. Okay, most probably they are the most common, okay, due to deflection of forces that are trying to split the lingual cusps. Minor fracture can be treated by recontouring and polishing, but if the fracture line is extensive, then the tooth should be planned for indirect restoration. You could note here, okay, this fracture line of the buccal cusp of upper first molar, and you could note the lingual cusps on the picture B of lower molars that are fractured because they are weak and not supported by either capping or tipping or bonded restoration. Finally, those are the textbooks I always refer to them if you would like for extra reading. Finally, feel free to ask me, as your questions are welcomed all the time. Okay, you could ask me by commenting to this video and I will reply to you as soon as possible, or sending me an email, and also I will reply to you as soon as possible. Finally, I would like to thank you for assigning this time to listen to me. Don't forget to subscribe to my channel and activate the notification and like this video